Hello everybody, I'm Dr. Shafi Yoon, Assistant Professor of Radiology at Medical University of Isfahan. Today I want to show you some head and neck cases. Let's start. Case 1, 36-year male with chronic left nasal obstruction and discharge. As you see in the left side, we have the coronal CT scan image that shows opacification of left maxillary sinus as well as ethmoidal and nasal cavity. We see that the central opacification is more hyperdense relative and compared to the peripheral side, and it's called double density sign. As you see in the MRI, T1 and T1 post-contrast images, we see enhancement of the peripheral mucosa and the central non-enhancing material. This is allergic fungal sinusitis. The most important radiologic findings is the double density sign, or also known as serpiginous hyperdense material that we usually see on the CT scan. On T2, it's usually low signal intensity due to concentration of manganese, iron, and in T1 post-contrast images, an inflamed mucosa lining has contrast enhancement. No enhancement in the central part that usually seen. Okay, let's go to the second case, part B. In case 1, part B, 16 years old male with recurrent attack of headache and postnasal discharge. In this coronal CT scan image, you see that opacification of left maxillary sinus that contain central calcifications. In another patients with same pathology, you can see that in T2 images, we see opacification of right sphenoid sinus that is completely low signal on T2. It is fungus ball or mycetoma. Predilection for the maxillary sinus followed by the sphenoid sinus, and the most important feature is the central calcifications that it's usually low signal intensity on T2. Case 3 or case 1 part 3, you can see that in the CT scan we see opacification of right maxillary sinus as well as ipsilateral ethmoidal sinus and nasal cavity, and in T2 FATSAT coronal and T1 post-contrast images we can see that we see something like serpiginous material or something like gyration. It's called convoluted cerebriform pattern that is typical for inverted papilloma. Inverted papilloma has a radiologic finding that is pathognomic for its convoluted cerebriform pattern that usually seen on both T2 and T1 post-contrast images. It represents altering lines of high and low signal intensity that somehow represents cerebral cortical gyration. And this part was sinus that finished. We go to the other parts. Case 2, part A. 18-year-old with recurrent submandibular swelling. Whenever we have recurrent swelling, we can usually think about something like congenital anomalies, as we can see in these images. In this image, we have axial, coronal, and sagittal images with contrast that represents a cystic lesion with peripheral enhancement that lies posterior to the left submandibular gland, lateral to ICA, and anteromedial to sternocleidoid muscle. Vallardidix, we can think about second bronchial cleft cyst type 2 because it, as in the history, we have that it's had recurrent swelling. The other less likely diagnoses include necrotic nodal metastasis, neurogenic tumors, and tuberculous adenitis. It's a second bronchial collapsis type 2. We have four type of bronchial collapsis: first, second, third, and fourth. That according to Bailey classifications, second bronchial collapsis divided into four subgroups. Type 1 is between platysma and sternocleidomastoid muscle. Type 2, like as in this case, between sternocleidomastoid muscle, submandibular gland, and lateral to the carotid sheath. Type 3 usually show a big sign as it extends between internal and external carotid arteries, and type 4 medial to carotid sheath in the parapharyngeal space. As we can see in this scan, type 2 is the most common type. Let's see. The other type, it's first bronchial collapsis, and you can see that the first bronchial collapsis is usually around or near parotid space and external auditory canal. Second bronchial collapsis type 1, as we can see in this case, is usually superficial and along the deep and adjacent to platysma and sternocleidomastoid muscle. Second bronchial collapsis type 2, as we can see in the main case, it usually lies lateral to carotid space, anteromedial to sternocleidomastoid muscle, and posterior to the submandibular gland. Second bronchial collapsis type 3, it's usually has a big tail. It's have a beaking between internal and external carotid arteries. And second bronchial collapsis type 4, it's usually in the parapharyngeal space. Third bronchial collapsis is in the posterior triangle. Whenever you want to find the posterior triangle, you should search for it behind the sternocleidomastoid muscle, as in this case. So whenever you show a cystic structure in the posterior triangle, think about two pathology. So one is cystic hygroma or lymphatic malformation, or third bronchial collapsis. And this one is fourth bronchial collapsis, that it's usually presented with recurrent thyroiditis. Okay, let's go to the next part, case 3 part A. In the OPG, we can see that a lytic bony lesion in the right mandibular ramus that contain an unerupted tooth in the right side. So what is the diagnosis? Another images, axial image of CT scan, a sagittal and coronal, the same pathology that shows an unerupted tooth with a lytic bony lesion. It's dentigerous cyst. Whenever you see a cystic cavity containing an unerupted tooth, it's pathognomonic for an dentigerous cyst, and it needs no further imaging. Case 3 part B, as you see that in the left side, in inferior part of mandibular body, you can see a lytic bony lesion around a root of a tooth, and it's a radicular cyst or periapical cyst. It's usually around the apex of an infected tooth. Case 3 part C, you can see that in the OPG, the left side, and in CT scan in the right side, we can see that a lytic bony lesion in the mandibular angle that does not contain an unerupted tooth, is not correlated to the roots of any tooth, and it's odontogenic keratocyst. Odontogenic keratocysts usually arise from dental lamina, and if it's multiple, we can think about basal cell nevus syndrome. It was the end of the part 1 case presentation. If you liked the video, please subscribe and like it. Thank you so much. See you on the other images.